if anyone's told you you've done a good job lately, but you're doing a good job and I'm so excited to see you. I know it's like short-term memory, but that's okay. We're going to do it anyway for the sake of consistency in starting this. A follow-up. Mumps is reportable. So mumps is a reportable disease. So anything in your MMR is going to be something to the local health department. So quick review from this morning just to get your brains off of surgery and back into peds. Which disease has 4 tremor spots? Rubella. Which means, what does measles have? Couple spots. What are the different names for the disease associated with parvo B19? Peds disease? Yep. Erythema, infectious, yes. What is the rash associated with that? Spot cheek rash. And then what, stage 2? And it goes everywhere. Yep, it's diffuse. And then what happens in stage 3? It's itchy. And then what happens where it's itchy? It's desquamates. Yep. What is the congenital heart defect associated with congenital rubella? PDA. Perfect. Your neighbor tells you that their puppy has parvovirus. You have a friend who is 35 weeks pregnant visiting. Are you worried? No? Why or why not? That's in the 3rd trimester. When are you worried about parvo? Second trimester. What are you worried about in 1st trimester? Rubella. What is the underlying infectious etiology of roseola? Human herpes number 6. Yep. So which number is this? 6 disease. Yep. Rye syndrome is associated with which classic childhood illness? Varicella. What do you use low dose amoxicillin for in children? Group A strep. Yep. What does your Scotch tape test for? And worms. What is your first line treatment for scabies? Permethrin. What's your other thing that is permethrin is your first line treatment for? Okay. So for the sake of consistency, we are going to continue to do that. So we are moving now into our ENT lecture. I know that you guys have already had the most amazing ENT class. Commander Irving is phenomenal, so you truly couldn't have had anybody do a better job. Again, I'm going to assume that you remember the diagnostic criteria, the anatomy, all of those things. So you will see slides on here that have some of those review things. That is just as a refresher for you. We're not going to go over those things. What I need you to study and to focus is what is the specific differences then when it comes to the kiddos and pediatrics. There's a ton of crossover. Peds ENT is functionally a bread and butter primary care. So this is one of those areas that the more comfortable you are with, the better off you are going to be for your pants and then just for life in general. So we are going to start with the eye. Quick reminder of your anatomy for what the eye is. Some of the pros and some of the things that have come up semester over semester and some of the things I see with other providers. So if you're like, yeah, I already know this, great. However, you would be shocked at the people that don't know this. So there is a difference between optometry and ophthalmology. Ophthalmologists go to medical school and then do a residency and or fellowship to be surgeons, eye surgeons. They do some of the medicine, but most of the time they are doing surgical procedures. Optometrists are the medical side of the house. So they are the ones doing most of your medicine, your eyeglasses, some surgical follow-up type things. Similar to how if you had a general surgeon and an internist, kind of in that similar vein. The thing that I specifically need you to know for pediatrics is that you don't send them to an optometrist. So if you want a child to have glasses, great, you can send them to an optometrist if they are over about the age of 5. If you have a younger child or if you need any kind of eye disease, optometry school does not teach them anything with pediatrics, so they need ophthalmology, okay? So that is just a big distinction in pediatrics, is young kids, if you are non-school aged, or if you need any kind of surgical correction, pediatric ophthalmology. It is a subspecialty, so it is a fellowship, so they have done ophthalmology and then they do pediatric ophthalmology, okay? So that's who you need to refer for any kind of medical or surgical treatment of a young infant. Other things to know, just to make sure that we are on the same, and the differences between these babies and young children and the adults that you learn. Back from block 1 as a reminder, they come out with a vision that's like 2200, 2400. All they can recognize is the mother's face, functionally, or a caregiver's face. And that crisps up really, really rapidly. We also talked about there's really no tears. So tear formation, so they are crying for hours and hours and hours with colic. They don't really have true tear formation up in those first weeks or months of life. So that vision is crisping up. First, they can barely see any faces. Then over a couple weeks, big objects or lights, or bright lights. And then by the time they're 2 months, your first thing that you're going to check for a 2-month is, can you track? Can you visually track? Will you put something in front of a child's face and will they follow it with their eyes? That's really your first visual milestone. So some people will call it visual tracking, fix and follow. We'll hear all variations of that. Do you remember the disconjugate gaze? So 2 months is when you first start checking that, but that disconjugate gaze, it hasn't quite crisped up yet. Remember, you give them till that next well visit to be outside of that standard deviation. So yes, that's correct. 4 months is when you're like, yeah, it's not normal anymore. Just a review from block 1. If at 4 months, they still have googly eyes and it's all over the place, that's ophthalmology. So remember, we don't send them to optometry for that. What you're worried about, why you're sending them at 4 months, is you're worried about strabismus developing. We're going to talk about that for kids specifically. The other reminder from block 1 is you're always going to check a red reflex on all kids all the time. It's one of those go-to. So when I see a child, especially if they're over the age of 6 months, I'm using the visual acuity screener. Takes a picture of that surface of the cornea, checking for the red reflex, checking for the light reflex with those pupils, making sure their eyes are aligned and there's nothing obstructing their vision. So really functionally, my technician is doing the visual acuity screen, and it's mostly a visual and light examination. Super, super quick, but gives you a ton of detail. Then 6 months is when you can do that vision screener. You could try to do some of the Snellens and shape charts. Really functionally, as the visual acuity screeners have become commonplace, we go to that now. Gives you better, more accurate information. And you also then are not dependent on the child and their communication or reading ability at that point. But if you are under the age of 5, go to shapes. If you're over the age of 5, the Snellen chart. Once you are school age, so over the age of 6, so you're in first grade now, where you're starting to actually really learn how to read, what first graders do, even though often they'll do it before. It's a skill in the first grade. That's when you should be 20/20. So 6 years old, starting to read, that's when you should be 20/20. We'll talk about how do you figure out what you should be in between then. As a reminder, 2200 is your legal blindness. And the most common cause, way back from block 1, of some visual impairment is that you were born prematurely. You had that retinopathy of prematurity where your whole retina was not vascularized. So how do you determine then what's normal? If we go from 2200 and we need to get to 20/20 by the age of 6, what do I do with these 2, 3, 4, 5, 6-year-olds? Okay, so there's a couple ways to do it functionally. What I learned is 3, 4, and 5 are flipped. So if you're 3 years old, you should be 20/50. If you're 4 years old, 20/40. 5 years old, 20/30. 3, 4, 5, flip those. If you're trying to figure out the 2 and 6-year-old, you could do the rule of 8s. Their age plus whatever the bottom number for their acuity should be should result in an 8. So a 2-year-old, so 8 minus 2, 6, so they need to be at least 20/60. 3-year-old should be 20/50, 20/40, and so on. So however you want to remember that, But what will often happen is if you see pediatrics and you have a brand new technician who's used to people being 20/20, they do the visual acuity for a 3-year-old and they say, oh my gosh, their vision is 20/50. You're like, that's great, totally normal for a 3-year-old. Don't need to do anything with that. So knowing what is normal is going to be important. I want you guys to know that. Again, hyperopia, farsighted, myopia, nearsighted. What I will say, and this is one of those reasons that it's part of your wellness visit for all ages, is because this manifests itself in children a little bit differently than you would expect. So both of these, hyperopia and myopia, can be things that children present looking very differently. So both of these, the most common way that I've seen them is school issues. So they'll say, they just have no interest in reading. They don't want anything to do with it. Or they are really struggling with numbers, letters, they're in the back of the room, they don't want to participate in PE, fill in the blank, right? If you have hyperopia and you can't see anything right in front of you, but you can see way out there, why in God's green earth would you want to spend time sitting in the classroom learning to read? How frustrating would that be? Conversely, if you're a child and you're like, I really want to learn how to read and I can't see the board, but you don't know that you can't see, or you're in PE and you're like, I'm going to get hit in the face with this dodgeball, right? That makes school not fun. So one of your first workups for any school complaint, can you hear, can you see? For these 2 reasons. So this is different ways that they are going to present. The other thing that you, as the primary care provider, are going to be in charge of is preventing long-standing strabismus and amblyopia. I think you guys talked a lot about this in Opta. Did you guys talk about this at all? Okay. So strabismus is when the eyes are not aligned. If you're looking dead on, you should be looking and seeing 2 of my eyes, not one eye over here, one eye over here, up and down. You should be seeing eyes that are convergent. When you don't, functionally it's called a lazy eye. You now as providers will no longer use the term lazy eye, you will use strabismus as your definition of that. And the concern for that, and the reason this happens is when you have both eyes, you have your dominant eye that is taking the first picture, and your brain is searching for the other eye to make a second picture to fill in that 3D and also confirm what that picture saw. So it's going to be doing those 2 things to the back of the brain. If this eye is giving a different picture or not a clear picture at all, especially in a child, the strong eye will say, I will take over, you just shut on down, and once the eye shuts down, eventually the pathway to the brain will shut down. And the area in the back of the brain will just say, I guess I don't get used, so I'm not going to form. And thus you truly lose vision of that eye. And so correcting strabismus so that you can get that secondary picture is going to be really important to prevent the brain shutting off. So eye misalignment, strabismus. Once the brain shuts off, amblyopia. So how are you going to do the nomenclature of this? So number 1, you got to figure out which eye is affected, right? If you have 2 eyes all over the place, so the eyes are all, like, how do you know which one's even affected? So number 1, which eye is affected? We'll talk about those tests. Number 2, then once you figure that out, the one that's affected, is it in? Is it out? Is it up? So esotropia, orphoria, exotropia, orphoria, hyper. Hyper is probably the most rare. If you see hyper and you haven't seen that before, you should call opto and be like, we should look at this right now. If it's all the time, it's going to be atropia. If it's just some of the time, it's going to be aphoria. It's like phoria for phase, just phases in and out. And then intermittent would be the times where you look and it's dead on, they're totally fine, but now the child, they get really sleepy, or their eyes are strained, their eyes are tired, and that's when you start seeing a deviation. So we'll talk about how to look at that. So we already talked about the misalignment of the visual axis and what happens. Amblyopia is not just, though, from strabismus. So you could have that strabismic eye that is wandering away and not giving the brain that secondary picture, that secondary input. You could also have significant refractive errors. So if you have a child that has either one or both eyes that's significantly myopic or hyperoptic during the time of development, your brain will do the same thing. So eventually we'll do that. The third thing is some sort of deprivation. So I will tell you, I had a couple of patients where they had large capillary hemangiomas that were coming over the eye. And so they had, their vision was obstructed from something secondary. So it could be a tumor, could have a hemangioma, could have a cataract, could have a retinoblastoma. But anything that's going to interrupt that picture that is sending the brain can cause the brain over time to shut down. So the 3 types. That's what I just said. So what are you going to test? How are you going to test to see this? Well, your first test that you're going to do is going to be your corneal light test. We used to call it the Hirschberg test. Really, I haven't heard it called that for a long time, so older docs may call it that. Your corneal light test is really looking to see, are those pupils aligned? How do you do this test? You shine the light. You literally shine the light in the eyes so you can see the light reflecting on both eyes. And it should be right, just medial to the center of the pupils. If it's not in both pupils like that, something's off. Okay? The specific entity that happens with children, I need you to be aware of this one, is called pseudostrabismus. So you're like, oh, this child has an eye that's super far in, so it usually looks like an esotropia. This eye looks like it's super far in. We got to get this kid to opto. You shine the light in their eye, and that light is dead center in the middle of both pupils. You're like, what has happened? What has happened is they have the face of a baby. The baby has a really wide nasal bridge, has a lot of extra folds, of epicanthal folds, and a lot of just baby chub. So when you have all of that together, it makes the eye look like it is further in, but it's really not. So literally just doing a corneal light reflex test will make a difference between I've totally concerned this parent and said maybe we need to have eye surgery, and this is totally normal, and they will literally grow into their face. So this would be an example of that. The top one, you shine the light, you see both light right in just medially to the center of both pupils, totally normal. You see the light lateral to the pupil, ESO, medial, exo, below, hyper, just for nomenclature purposes. This is an example of what pseudostrabismus looks like. So if you were to not look at the pupil, you look at this baby, and you're like, well, I see sclera on one eye. I don't see sclera on that medial side of the other eye. This looks like an esotropia. But once you've shined that light, and you can see it reflecting, it's dead center in the middle of both pupils. Then you look and you're saying, oh, this baby has a really wide nasal bridge, has a bunch of little baby chub, and pretty round, normal baby eyes. So this is a perfect example of pseudostrabismus. What do you do with pseudostrabismus? Observe. You tell them you have a normal baby who's really, really cute. That's all you gotta do with them. So make sure you can pick out strabismus versus pseudostrabismus from an example given or with words or the picture. Now your cover-uncover test. Do you guys remember your cover-uncover test? Which one is which? That's fine. I'll pretend that you were brilliant. I'm just going to say it for me. Cover test is when you are trying to, you have a fixed eye and you're trying to determine the eye. Cover-uncover is when you're like, what is happening? Okay? So let's say that I have one eye that's off and you don't know which one it is. For our purposes, we'll say that this eye is the good eye and this, my right eye, is going to be my bad eye. So if I'm doing the cover test, if I cover my bad eye, does this good eye change at all? If I cover the bad eye, what happens to, or if I cover the good eye, what happens to the bad eye? Yeah, it corrects. So in the cover test, your bad eye that is fixed is going to rapidly change because now you've taken away the sensory input from your good eye. So the bad eye is saying, okay, fine, right? Fine, and it'll snap into place, okay? Your cover-uncover test, the way I always think about this is like, you know, like when somebody is right on the edge and you're like really trying to hold it together? Like in life, in IPAP, emotionally, pick your genre. right? And you're like, I've got this, I'm gonna hold this together. So your eyes are straight on, and now you cover one eye, and this eye, once you cover the bad eye, the eye's like, oh thank God, I can fall apart. Then when you uncover it, it snaps back, because it's really trying to hold it together. And so you're really trying to pull out an intermittent phoria for the cover-uncover. So for the fixed one, you're like, that's all the time, I just don't know which eye it is. That's the cover test. For the ones where you're like, intermittent, you're trying to pull out which one is trying to hold it together, your cover-uncover test. So if that makes more sense in word form, cover-uncover test. So which one is this, and why? What it says on the slide. So why is this the cover test? Because it is fixed, right? It is fixed, and so you're like, is he looking over to one side, or is the eye that's straight on the good eye? Don't know. So going to do the cover test to see which one snaps into place. And the one that snaps into place is the one that is not good. So the specifics then, once you do the cover and uncover test, you know which eye it is, you can tell it's an ESO or an exotropia. Which one of those do you need to be the most concerned about? So that's what we're going to talk about. So esotropia is one that is often congenital. So that's why pseudostrabismus is often confused with that, because your esotropias are often the ones that you're born with. And if it's esotropic upon birth and it really never goes away, those are the ones that really do need the surgical intervention pretty early. So those are truly the ones that need to go to ophthalmology early. A lot of times this is due to a significant refractive error, so it's one of those three causes. And this will be one that before surgery they really will try some patching or some different types of glasses. It's kind of interesting. Did I put it on? I don't think I did. So they'll do a couple of different things. When I was going through, it used to be like, nope, they need to be patched or in glasses or something all day, every day. Now they've got it down for really just a couple of hours a day. So there's a couple of different ways that they can do it, and it's really provider specific in the ophthalmology world. So some of them, okay, if you have this, remember this was my good eye, this was my bad eye, which one am I patching? Your good eye. Why? Yeah, you're going to force that bad eye to make those pathways in the brain work. So I'm either going to patch the good eye, forcing that bad eye, or I'm going to have glasses where I make the good eye obscured, and then the bad eye is just clear. So you're like, wait, what? Yep. So you functionally ruin this eye, and then this one's just clear. The other thing that they will sometimes use is atropine drops. And so they'll just, again, obscure the vision of the good eye and force that bad eye. So you can do drops, patching, or glasses. So provider specific and what the kid will tolerate. You'll have some different options there. Now, if you've been seeing this patient and you're like, your eyes are normal, we did your well visit, 1 year, 2 years, 3 years, 4 years, 5, we are doing great, love the family, know it all. And now they come in, they're 6, 7, 8, 9, and now they suddenly have a new onset esotropia. That's when you should pucker, because it wasn't there before. Now you need to know what kind of tumor is there that is pushing on that eye, that is moving it. So a new esotropia, once they're in school, is you need to scan that, and it's a tumor until otherwise. Okay? So much like block 1, where you're like, if you saw prepubertal testicles that are large, that's a brain tumor until otherwise. New esotropia is also a brain tumor until proven otherwise. Your exotropias are a little bit later in life, so they'll still do some of the observation, patching, potentially surgery if it gets a little bit more extreme. Both of them will still require ophthalmology. They're just, again, exo, you're seeing it a little bit later onset. If I have not beat the red reflex into you by this point, I don't really know what to tell you. Again, if they don't have it and they have leukorrhea, the ones that you're concerned about, do you have an infantile cataract? Do you have a retinoblastoma? Is there some serious pathology going on with the retina? Or did you have that incompletely vascularized retina with retinopathy of prematurity? And then again, if you just want to study this way of the way that the different red reflexes could be and what they could be from, here for you. There's a See Red campaign that the American Academy of Pediatrics did for a long time to make sure that it became part of the standard of care to do a red reflex for every child, all the way up through their development. Okay, so what do you do then? So as a provider, you're like, okay, so I did that, but when do I do like full exams, and if it's wellness, like what do I do? So if you have a history where you were early, and how are we defining early? Come back from block 1. Yep, less than 37 weeks. I would make sure that you do a full eye examination. So usually retinopathy of prematurity is less than 32 weeks. That's something to consider. For any premature birth, did your retina vascularize? First thing. Second thing, we talked about with cerebral palsy and Down syndrome. Do you remember what those kiddos with Down syndrome had? What were those pathognomonic spots that they ended up with? Somebody said it. Brushfield spots, yes. Yep, so they will have those, and then they will have some of those significant refractive errors. And then any school performance. So anytime they come in with any concern, rule out hearing and vision as your first things. The other things to think about, if they come in with any kind of nystagmus, so nystagmus needs to be worked up no matter which direction it is, especially if it's new. So ophthalmology will need to see any kind of nystagmus. Any kind of strabismus needs to go immediately for referral to a pediatric ophthalmology. Anytime that they are outside of that range of their normal vision for their age. So anything that's abnormal, or if there's a significant difference in the eyes. So let's say one eye is 20/20 early, and one eye is 20/40, still normal, like 4 years old. So it's like, oh, they're supposed to be 20/40, and this eye is 20/20. You're still going to send them because you're worried about that mismatch and that part of the brain shutting off. So a 2-line difference, or anything that's not matching them developmentally, you're going to send, and then any abnormal red reflex. Yes, sir?
This strabismus, is it any strabismus after the age of 4 months?
Yes.
Okay.
Yeah, so if they still have that disconjugate gaze and they're in that 1, 2, 3 month range, let that fly. Yep, let that fly. Yep, once they're at that 4 month visit and you're like, ooh, then you go. Good clarification. Okay, clear as mud for all that eye stuff? Okay, conjunctivitis. This was probably beat into you from ENT and infectious disease somewhere in there, so some of that is a review. So kids are miniature humans. Viruses and bacteria, allergies, all the same things are going to get them just the same. It's going to just present a little bit different. Some specific predisposing factors that make it super common for kids and for little babies. Number one, they have an entity that most of us don't have, where they have nasolacrimal duct obstruction. It's very, very common. We'll talk about that a little bit later in this. This is the first time their sinuses are seeing anything, so you see a lot of teenagers, a lot of kids with sinus issues. More likely to have otitis media than the adult based on their anatomy. And then when they have any type of allergic or irritant symptoms, you see in children, they rub. So you have their grimy little fingers with all of their little pinworms that they had this morning, now rubbing those in their eyes. Okay? So you can see how this is a scenario where they are more likely to get a type of conjunctivitis. Again, a review for your anatomy. A couple of things when you're looking at conjunctivitis as a reminder from your ENT class is that most conjunctivitis, the most normal, quote unquote, normal conjunctivitis, routine, run-of-the-mill conjunctivitis, is going to be limbic sparing. And I said that in one class and then realized that maybe you didn't remember where the limbus was. This is what part of the eye the limbus is. So when you are looking at that, one of the ways to comment on an exam, because it will change your differential, is the injection on the eye, is it limbic sparing or is it limbic involving? So it's going to be a big differentiator for a child's differential. So is it limbic sparing or limbic involving? When you have true conjunctivitis, it should be limbic sparing. So we're going to talk about the 4 distinct types for children of conjunctivitis. We're going to go in depth for each of these, but just so you know where we're headed. There's a neonatal conjunctivitis, then all your different infectious, then your allergic, then your chemical conjunctivitis. We'll talk about all of these. So for neonatal conjunctivitis, do you remember what your eyes and thighs were? Block 1, what were your eyes and thighs? Vitamin K, yep, and erythromycin ointment. What was that erythromycin ointment for? Gonococcal conjunctivitis. Oh, there it is. What did we used to use? I think it's on there. Yep. What did we used to use before we had erythromycin? Silver nitrate. That was a terrible idea. Let's cauterize the eye, right? You're like, why in the heavens would we do that? Do not know. But there are still some places that the risk of gonococcal conjunctivitis is still significantly high. So I haven't seen it, but I am told there are still places that will use silver nitrate. So that's going to give you a type of chemical neonatal conjunctivitis if silver nitrate is being used. There are a few kids, I've only seen a handful over time, that will have an issue with the erythromycin ointment of the eyes and thighs. So most of the time, if they are truly erythromycin allergic or something, they could have a response to that. But functionally you can, that should be much lower on your differential. The timing of this is going to matter. So if they come out the chute those first day or two while they're in the hospital and they have something going on, most of the time you're thinking, ooh, it is something that we have put in their eye. If it's now your 2 to 4 or 5 day follow-up and they come back to you and there is something in the eye that is not normal, that's when you need to start thinking of these different bacterial etiologies. Most concerning being the gonococcal one. So that would be a question, did you actually get the erythromycin ointment? Looking back at mom's chart, was she actually tested and have a negative gonococcal? Did something happen between the last testing and when she delivered the baby? E. coli can be another one that you see there. So staph and E. coli, there's contact with the skin. There's contact that can produce those. So one of the things to think about. Then you're later, so late onset. So it's the same as the rest of HSV. So if you're a couple weeks in and you're already thinking, oh my goodness, is this going to be neonatal HSV? That should be something that crosses your mind as well. Do you remember what those lesions are called? Dendritic lesions, yeah. So if you see a staining pattern like that, you should pucker and call ophthalmology like right now, because that would be a pattern of HSV for anybody, but particularly in a kid. And I would say the most common thing though that we see is this concern for chlamydia. So chlamydia is usually not going to be super abundant, comes on bilaterally, and it's usually, if you're thinking about where do I remember this, it's about the 2-week well mark. So if they're coming in a couple weeks in with bilateral drainage that you're like, this doesn't quite make sense. They got erythromycin ointment, okay, I know it's not going to be gonorrhea most likely then, it's not copious, it's a little bit later, I need to start thinking that it is chlamydia. These ones are important to know because there's a lot of different routes depending on what it is. So one of the reasons that eye stuff is really nice is that you can take a sample of this. So this is relatively easy to be able to culture. Take a swab, send it to the lab, boom, now you know what your etiology is. So that's really nice. You're not having to cath or get a little vein or any kind of thing like that. You take a swab and get a sample. So while you're treating, while you're using it based on epidemiology, based on the history, based on your presentation with the kid, these are the ways that you would need to treat these various different entities. So if you think that this is truly gonorrhea, meaning there is copious drainage, it is early, they didn't get erythromycin, something to that effect. This is your most aggressive treatment because you have to hospitalize this baby. You're like, hospitalize? Why in the world are we hospitalizing this baby? Well, the irrigation that you are having to do for the copious amount of drainage for a neonatal gonococcal conjunctivitis is so intense that the baby needs to be hospitalized. They typically will not eat very well after that. You can bagel them if they do that, if you're having to do these intense irrigations, and then you're having trouble keeping them hydrated and their glucose up. So if you're going to do these intense irrigations for gonococcal conjunctivitis, hospitalize these babies. And then your ceftriaxone is IM or IV. So most aggressive for gonococcal. Chlamydia, medium aggressive. So we've taken a sample, we know it's a little bit later, a little less purulent, but now this is a PO treatment. So even though it's topical in its presentation, your treatment is PO. So PO erythromycin for 2 weeks. Pseudomonas, I can't say that I have ever seen this, but in the literature, and it's still part of your pants, so it is on here. So Pseudomonas in that neonatal period under a month, it's going to be IV gent, still that irrigation, so you would still probably hospitalize them. And then you can also do the topical treatment. HSV anything, by this point you should just know that it is going to be IV acyclovir because you are worried about the big, bad, ugly neonatal encephalitis with HSV. And then if you think it's those skin, or it comes back and it is skin, so staph, or really the E. coli that you see as well, you can do the topical. So one is IV-IM, one is PO, functionally then one is the topical with erythromycin or polyform. We'll talk about those two. Those are when you're little. So those are those like 1 month old, oh my goodness, big, bad, ugly. Is that really what we see the most? Is that what we see the most? No. No. What do we normally see? We normally see, oh, I have pink eye going through daycare. Oh, we have pink eye going through the iPad classroom. Oh, we have pink eye somewhere, right? So this conjunctivitis. That's my time. We started at 2:30? Okay. You guys are like, oh my god, yes, sometime. So the most common etiology, as with anything, is going to be viral because of that transmission. And when you are thinking, what's the most likely? It's going to be adenovirus for children. So children, remember if you have fever and a rash, it's going to be XYZ. So what I need you to do is fever, rash, eye symptoms, likely adenovirus, because it adds the eyes. Adenovirus adds the eyes. That is typically your viral pink eye, going to be an adenovirus. Super, super contagious. And it's usually very watery in nature. So it can be unilateral, bilateral. They just kind of look like they're tearing. It's a little thicker than tears, but not quite this like copious like ick from some of it. This one I will say is interesting. So your supportive treatment, wash the eyes, cool compresses to make sure they don't have as much extra swelling of the eye. Now, but what I will say is, this is what you can decide on as a provider. So just so that we are all on the same page, do you treat viruses with antibiotics?
No.
No. However, this would be one that I would say overtreating, and using your brain to think through this is a reasonable time to overtreat. So you might look at this kid and think, you have a runny nose, you have a cough, you have a fever plus or minus, and you have red eyes. This is adenovirus. They're getting better, but daycare won't let them go back. School won't let them go back until they have been treated. You can die on that hill. You can die on it. You're correct. It's viral. Not going to do much. However, that's a hill that I'm not willing to die on, personally. And what will often happen is it's so irritating to the child, they rub, and seed themselves with a secondary bacterial infection. So this is one that I go ahead and overtreat. Don't die on that hill if you don't, unless you really want to. I go ahead and overtreat viral conjunctivitis to help prevent secondary bacterial conjunctivitis. So that is me. You do not have to practice like that. You can just say, here's some Refresh lubricating drops. Have a nice day, and that is completely appropriate as well. This is just one where, because of the diagnostic challenges and because of what is required with school and coming back to work, and that secondary bacterial from a kiddo rubbing their eyes, something to think about. This is what that top child has, a viral type conjunctivitis. The eyes are red, it's pretty watery, bilateral, you see some matting of the eyelashes, pretty typical for a viral conjunctivitis. The other pictures on the sides, one, you're seeing it's highly vascularized, so it's bringing more blood to the area, more cytokines, more inflammation, versus what you're seeing at the bottom is some of the blebs or some of the cobblestoning. Which one is going to be more acute? The vascularization or the cobblestoning? Vascularization, yep. Anytime you see cobblestoning, it's looking at these areas of chronic inflammation. Tells you something more chronic is going on. So if you see that, you can see that any mucosal. Typically you'll see it on the eyes, you see it in the back of the throat. If you see cobblestoning in the back of the throat, you're like, that's more likely gonna have some chronic postnatal drainage or allergic component than this acute virus. The ones at the bottom, the kid with bilateral, you see that there's some blood pooling, venous pooling under his eye, copious amount, more likely bacterial in that case. Can be unilateral, can be bilateral. Which takes us to that bilateral. So now we are looking for what's the most likely cause of that. So in the older kids, the most likely cause is going to be your heat bugs. So your Moraxella, strep pneumo, H flu, your things that you're seeing over and over and over for any of these heat things, and adults even, are going to start seeing in the eyes as well. So that's what you're covering for. I will say this is one area that people really want you to believe them. Again, another one of the reasons that I go ahead and overtreat a lot of things. Parents really want you to believe them that their child had a fever, and so they will just leave the child miserable and come in with a fever just to prove it. Don't do that. Don't be that provider. Same thing for this. If the parent's like, there's copious amounts of drainage from the eyes. I've had parents that the child walks in like this because their eyes are just matted shut. Let the parent just have them wipe the eyes away. It's fine. Or have them take a picture. With bacterial conjunctivitis, it's not usually just matted once. It's usually so copious that they literally come in with a rag and they're wiping the drainage away. You ask them one question, you look back at the kid and it's pulled up again. That's how much copious amounts of drainage means. Your antibiotics are going to be covering those things that we talked about. They're typically going to be either erythromycin ointment or a polymyxin trimethoprim drop. Polymyxin trimethoprim drop, so polytrim is what we call it. If you needed that refresher of bacterial versus viral, what that's going to look like and manifest, just make sure you can differentiate those with the different symptoms, different pictures. Your antibiotics to know this, so those are erythromycin ointment, your polytrim drops. This is a provider choice then. It's going to cover for functionally the same things, and so different styles of how you're going to prescribe this. So sometimes you want the drops. Super easy to get a drop in, but you have to have more accuracy, and you have to be able to hold somewhat still. Erythromycin ointment, once you get that ointment in the eye, your vision is obstructed. So typically, if you have a parent that is a little wigged out or a little bit weirded out by the eyes, and you have a child that is non-ambulatory, so they're just kind of laying there, just hanging out, that's the child that I will usually do the erythromycin ointment for. Once you're mobile, you have a kid that's up and mobile and moving, and you try to put an ointment in their eye, they're just going to rub it out, and now you've compounded the problem, because now they're rubbing their eye, and they're just going to rub out the ointment. Okay? So typically, this is how I practice. They're ambulatory, and the parent is okay with it. Say, let's do the drop. Let's see if we can get it. If they're non-ambulatory, or if your parent's really weirded out by doing it, okay, let's do the ointment, but just do the ointment at night before they go to bed. That's how I practice. Other options you can do are the fluoxetine, so oxy or Cipro. Are we close to well, I'm going to finish this. Allergic conjunctivitis is going to be different than your viral or your bacterial type. And the biggest thing is going to be twofold. Number one, onset is bilateral. So it is not ever going to start one eye and then the other. Its onset is bilateral because it is a systemic response. So the whole system is affected, thus the eyes are going to bilaterally be affected. They're very, very itchy. So yes, you can have some irritation from viral or bacterial conjunctivitis, but the hallmark is bilateral onset and extremely pruritic eyes in this kid. The cobblestoning we talked about is more likely going to be there because it is chronic in nature. And when you are thinking, well, maybe I could just give Zyrtec, maybe I could just give Claritin, you can, doesn't get into the eye very well, so it's not going to be as good as if you are using a nasal steroid. So a fluticasone, Flonase, something like that, is going to be much more effective for your eye symptoms than your systemic antihistamines. So that is one thing that I often see providers do a little differently, is they say, well, we're just gonna try a Zyrtec, or or cetirizine, or loratadine. We're just gonna try that, versus doing true treatment of choice, which would be your nasal steroids first. So don't miss that. Somebody misses that every semester. Again, for studying, just make sure that you can distinguish the difference. If I give you what this looks like, viral, bacterial, allergic, neonatal. Remember, how old are you for a neonate? Less than a month. So is it going to be neonatal if they're more than a month? No. It's bilateral onset and pruritic. Which one is it? Profoundly, there's cobblestone, yep, allergic. Yep. What's the virus typically associated with? Adenovirus, yep. So make sure you guys can nail those. Your differential, then, one of them is going to be ciliary flush. That would require ophthalmology on board, so that urgently. So it's way different than, I'm going to treat this with some pretty conservative treatment. So that's why your limbus is going to be such a key part of your physical exam. It's the limbus spared. It's going to be an urgent referral. So your exam is going to drive that. And then any other itis. So any other part of the eye can be inflamed as well. So you can have a keratitis, a uveitis, an iritis, any of the other itises, where you have a lot more eye pain and a lot more light sensitivity. So your differential, make sure that you don't narrow everything into being conjunctivitis. However, common things being common, that is what I want you guys to focus on for our portion of this right now. In ciliary flush, when you see that, more injection coming right to the edge of the pupil, versus it kind of gets around the pupil and it spares it a little bit. Okay? So non-limbic sparing, limbic sparing. It's your big differentiator when you're using that for talking to ophthalmology. This is a good place to stop. Let's take 10, come back at 3:30, and we will have 1 to go. I feel like we're doing pretty good. You guys are really hungry. 4 hours of listening to me today, quite impressive. Well, unless the last hour falls apart, which I guess. Yes, I know this lecture has a lot of slides. This is a 3 to 3.5 hour lecture, so we will not be getting through everything today. So don't think I just understood all of this. Okay, other things that are going to come up for children. So blepharitis is going to be one thing that comes up often, because when we get to the derm lecture, we'll talk about how children and babies specifically have a seborrheic dermatitis. So now if you have this staphylococcal infection right on that eyelid, right where you meet with the meibomian gland, now you have the perfect setup for this eye irritation. This will be irritating on the outside as opposed to the inside of the conjunctivitis. So remember, those slight distinctions in the anatomy are going to change your differential, obviously, and the way you're going to treat this. But because it is so close, with every blink, this child can experience a kind of a foreign body sensation or very, very irritating or burning sensation. So if they are verbal, that's what sometimes they will try to say, is that it hurts. And a lot of times it's trying to describe that foreign body or hurting when they're blinking sensation. That will cause them to rub their eyes again, and so now you're back in the same pattern where you can get a secondary conjunctivitis from the blepharitis. So how are you going to treat that then? Well, first, you want to get as much of the good eyelid hygiene as possible. So what does that actually mean? How do you actually do that? It's really actually pretty difficult. You're trying to wash the eyelid itself with a tear-free shampoo and a Q-tip. So you're really trying to get all of that off to de-bulk the burden of staph and the extra skin that is right there at the eyelid. Now, why would you want to use tear-free shampoo? It's going to hurt your eyes. What makes something tear-free? The bottle. Love that. What makes something tear-free? Yes, so the surfactants are mild, The pH matches the tears, so they don't have tears, and then it is slightly diluted. So that is what tear-free, if you're like, what is this Johnson & Johnson or whatever, tear-free shampoo has those three elements. A mild surfactant or mild breakdown, it's gonna break down the oils, slightly diluted, and then the pH is the same as tears, so it's not gonna irritate the child's eyes. You can also do warm compresses here, and then don't be afraid, again, to kind of over-treat in some ways with those topical antibiotics to prevent a secondary bacterial infection from happening. One of those entities back in the beginning with those neonatal conjunctivitis on your differential is going to be that nasolacrimal duct obstruction. So the other word for that is going to be dacrostenosis. It'll be different than if it's infected. So this one is just the obstruction and stenosis of that lacrimal duct. So what will happen is that a baby's lacrimal duct is so small and it is so new to the world that it will genuinely stenose down. So what is the lacrimal duct trying to do? Yeah, it's going to drain all the tears, right? So if you don't have that, what is this baby going to present like? Watery eyes that are just draining. So we've already learned this baby, if it's really early, they don't have a lot of tears. And if they're not having one of those viral symptoms that's conjunctivitis, if it's just eyes, then this probably actually isn't conjunctivitis. They're tearing because they have the nasal lacrimal duct obstruction from the stenosis. So it can be a little erythematous, or it can be a little edematous and a little puffy, but most of the time you will have no symptoms other than this copious amount of what looks like tears. So it's different, again, it's not matting the eyelid necessarily, it's just looking like crusting as it dries, because it's functionally like tears that's on there. What you're going to treat then is with super fancy duct massage. And so the parents will look at you and be like, really? You just want me to massage the duct? And you're like, yes, I do, because I want to break up that stenotic membrane that is there to allow that canal to open up. So a common misconception is that people are going to want to try to massage up the canal. Now you've just put the finger closer to the eye and closer to seeding it with further infection. So what you're going to tell the parent to do is put the finger right at the eye. Do you feel that little bump on your own eye? You can feel the lacrimal duct there. Feel that little bump and then pull down. And that is what they are doing over and over and over to massage that with clean hands. We're massaging that to try to break up that membrane, to break up the lacrimal duct obstruction and prevent then the dacrostenosis. So that's super common. We see that all the time. We see a lot of kids, they get antibiotics, they get ointments, they get oral antibiotics, they get all kinds of stuff, and the parents come in, they're still draining, they're still draining, they're still draining. That makes sense because the duct is obstructed. Right? So before you start just throwing antibiotics again, make sure you know what you're treating. What these can present, and eventually can present with, if untreated, is dacrocystitis. So now it actually is infected. So now you have a secondary staph infection in that obstructed duct. And so it's going to cause this localized and pretty profound infection right there because nothing can drain. So you get the staph in there, and then it can't ever get treated, get out, get nothing to do with that. So a lot of times you'll start and you'll say, hey, this is pretty mild, let's start with the duct. Let's try to do the warm compresses. Let's try to clean the eyelids, make sure we decrease the staph burden. And now it starts to get worse, and it starts to look like this. Now we start worrying about the eye itself, and is it going to seed into the eye? So once you start getting severe, and if we're saying severe, if you're looking at the eye and you go, ooh, like that's kind of how you're measuring severe in a baby. Does it look like this? Does it look so that you can see it very, very easily? It looks angry, it looks erythematous, it looks pronounced. That's going to be severe. That's when you're going to be treating it with oral antibiotics and saying, hey, ophthalmology, I need some help. So, mild, you can totally get away with as the primary care. When it looks like either one of these, That's oral antibiotics in ophthalmology at that point. Other things that are super common for kids are going to come in with. So hordeolums, or as most people on the outside are going to call them, styes, versus chalazion. So again, this is going to be another version of a staph infection. And usually it's right at those glands of Zeiss, or Zeiss, however you want to say them, right at the follicle base of the eyelash. You can have external or internal depending on where those are. So internal is going to be the meibomian glands. And this is super painful. So your styes or hordeolums are painful because it is an infective process. So an infection with that staph is going to be what is so painful. We're just trying to get this to drain. So much like the duct here, the first treatment is just trying to get it to drain. So compresses, NSAIDs because it hurts. So your NSAIDs again are not going to change the course of it, but it's going to make the child more comfortable. And what you're looking for is that I expect this after a week or two because there's the open follicle right there. So if I've done all the things to release the burden, to open up those follicles, I expect the body to drain that on its own. If it's irritating, again, you could do polymyxin or that erythromycin ointment at night. If it's a week or two, let's go ahead and send them to ophthalmology because it can become a small little isolated infection there. But very painful. So if you see something on an exam question, you're like, I don't know which one that is. The patient comes in and it's painful hordeolum versus the chalazion. So at this point, it's now chronic. So now it's a chronic, not infective, but inflammatory process. So very similar area of the eye, but now that inflammation has taken hold there, and so it's not tender, because it's not infected, and so it's a much more chronic process. So not going to hurt them. And still do the compresses, still small should resolve, but most of the time for a true chalazion, ophthalmologist is going to have to go in and either inject it with a small amount of steroid or do an IUD. This was one, for whatever reason, I just always thought was harder to remember, so I thought this one was kind of funny, and I put it in there. So know the difference between which one hurts, which one doesn't, who needs what. And if you're telling a patient, I'm sending you to ophthalmology, what can they expect of each? Which takes us to some of the end of the eye. So you probably learned this, and we're going to just make sure we hit it from the standpoint of the child as well. So I don't love the way that it is the nomenclature of this. We used to call it periorbital and orbital, or around the eyeball or the eyeball. And then we changed it now to preseptal and orbital. So I've never understood that. Why don't we have either orbital or periorbital or preseptal, postseptal? But nobody asked me, so I'm off my soapbox. However, periorbital, if you hear that, the same as preseptal. Cellulitis, so by definition, cellulitis is going to be the skin around the eye. So it's not the eyeball itself. It's in the name, periorbital or preseptal cellulitis. Skin is what is infected. With your typical stuff. Staph that's on the skin, strep that's on the skin, MRSA that's on the skin, strep pneumo that's on the skin. This one, because it is not the eyeball itself, you're not going to see the eye pushed out. You shouldn't have any specific eye pain because this is just the skin around the eye. It's functionally what's going on. If you can make this diagnosis clinically, so this would not be something that I need to do a CT scan for. A lot of people will be like, but what if it's the eye? I need a CT scan. Like, if you really think that it is the eyeball, you need to be going to the hospital. We'll talk about that in a second. So for preseptal, you do not need a CT scan. You do need oral antibiotics. Because this can seed, so this is one of the first places we've been like, yep, oral antibiotics, that's on you. So oral, usually Keflex or cephalexin is my go-to with this, or oral amoxiclav. Oral Clinda, has anyone ever tried liquid clindamycin in this room? Liquid clindamycin is the most disgusting of all the antibiotics. You can prescribe it. It's going to be very difficult for the child to take. So if you see that in the child, and it's liquid, it's really, really gross. So my go-to for this is cephalexin. And And I will promise you right now, I'm not gonna put clindamycin as an answer for this, because I would never want some poor child to have that. If you have that MRSA concern, if there's something in a question sim that tells you the entire family is colonized with MRSA, older sister has had MRSA, whatever, doesn't matter what it is. If there's something in the question sim for MRSA, make sure you cover for that with Polytrim or Bactrim. I'm not Polytrim, trimethoprim. And then you bring this kid back every day. So this would be a kid that you're saying, yep, I saw you in clinic today, I'm not gonna get a CT scan, we're gonna start cephalexin, and I'm gonna see you on my schedule first thing tomorrow morning. So every 24 hours, you're bringing that patient back because you have a very low threshold for ophthalmology or the ER. Make sure it doesn't seed. But preseptal cellulitis, super manageable as an outpatient clinic for a kiddo. This looks scary though, when you're like, is this the eyeball? I don't know. Is it? It might be, is the eye involved? Right? But there's no proptosis of the eye, there's no eye pain, there's no vision that's affected. So it is the skin around the eyelid, preseptal or periorbital cellulitis. It's in the name. Orbital cellulitis, which by definition I hate that name because you're like, it's not the skin, it's posterior to that. We'll leave it as that. It is when you have that infection post-septal, so inside the orbit itself. So the outside bacteria has now seeded somewhere else. So typically, you will see something where there is a prior sinus infection. They'll give you a CT scan. They'll tell you, oh man, I just had an ear infection, I just had something else, and you're thinking it probably seeded somewhere else. Your same bacteria, your same heat bugs as ever are going to be those ones. And this is how you're differentiating. The things that you checked to make sure it was safe with preseptal are now there. So you have proptosis, you have eye pain with movement, you have vision changes. All those things you didn't have with preseptal, now you have, and now you're really worried about that. So where do you send this patient? Ophthalmology or the ER, right? What is ER for? Life, limb, or eyesight, right? So this is one of those eyesight things. So this is a true emergency. You're at life, limb, or eyesight. You are sending them. I feel like there was something else I wanted to say. Oh, this is just one provider to the next. If you're working in any kind of clinic or any kind of aid station or any kind of anything, train your technician that anytime somebody comes in with a headache or any eye complaint whatsoever, that your technician does a vision screen. Like just a standard across the board. Like that's part of your vital signs. Don't even ask. Do it every time because you will keep yourself safe that way for any headache, any vision complaint. That was free. Okay, so now you're seeing the CT scan. And what this is trying to show you, just so that you don't miss this on a pants type question or something, is if you get a CT scan and you're like, well, I see a whole lot of gunk, I don't even know what that is, but I'm looking at the sinuses, and on one side I see air, the other side I don't see any air. Now I'm seeing it seed over into the eyeball. They're probably asking me something about orbital cellulitis. So that's just an example of one of the things that you can see. And as a reminder where that septum is. Again, true medical emergency, hospitalization is going to be key. Likely your blood culture is going to show something. And the reason is because it typically seeded from somewhere else. So when we say seeded, usually traveled by blood. And so if it traveled by blood, a blood culture is probably going to show something positive. So it's going to be super, super helpful in your management. Your broad spectrum, because you're worried about that MRSA coverage, MRSA is always going to include MRSA coverage. So this would be vancomycin and the third generation cephalosporin. So ceftriaxone or cefotaxime. It's going to be your go-to, both of them together. And because you're worried that it got into that post-septal region, and I think if I'm right, this is the first time we've seen it, this is a CT scan. So we haven't seen that for kids at all yet. This is an absolute post-septal or an orbital cellulitis. CT scan this kid, and because it is for surgical planning. So opto is going to need this for any kind of surgical intervention. So a CT scan is absolutely part of your workup. So they come in, to the hospital, you're like, oh my goodness, this is big, big, bad, and ugly. I'm gonna get blood cultures, something's coming out of the eye, I'm gonna culture that as well. I'm gonna start broad spectrum antibiotics with MRSA coverage, vancomycin or ceftriaxone, and I'm gonna get a CT scan. I'm gonna call ophthalmology. That's what you at the PA level would be expected to do. I just threw this in there because I've seen this as one of the questions as a follow-up. What is one of the complications? This would be like a fourth order question. They give you something, you have to get to orbital cellulitis, and then they ask what's a complication of orbital cellulitis in a child. So one of the most common, even though it's not that common, most common is going to be a cavernous sinus thrombosis because all of your anatomy is connected there. Okay, so it's just one of those things to kind of tuck away. Is if you see somebody that had orbital cellulitis, the thing that you need to watch out for on your differential if they came back would be an orbital or cavernous sinus thrombosis. Other things you can see, there could be some permanent vision loss, there could be an abscess that forms somewhere else, but things to think about. Studying, when you are studying orbital versus periorbital, preseptal, making sure you can tell the difference. And then I liked this one. I liked this picture because it really gave a good picture of the external skin and the infection there and why it looks very similar compared to post-septal, what is actually infected and where that's pushing and why one has proptosis and so much eye pain. So, what about this? This patient, what do you think this patient has? Orbital cellulitis. Why? So you have proptosis. What else? He looks sick. This patient looks toxic. Looks toxic. What else? There's one other thing. Yep, you have a widened bridge. You have a significant erythema. And then the reason I put this picture in here is use your context clues, right? What's he wearing? A hospital gown, right? So if you're like, I don't know which one this is, on your pants, this is a hospital gown. This is orbital. They're hospitalized. Okay? Use your context clues for things like that on the pants. Because they're going to give you things like this that you're like, oh, well, yeah, there it is. Right? Hospital gown. But yes, this is a sick child. Very sick. So what are you going to do? Where are you going to send them to? You send them to the hospital. What are you going to do when they're there? Antibiotics. What are your broad spectrum antibiotics? Think. And a third gen cephalosporin. What are you getting? What labs? Culture. What kind of culture? Blood culture and anything that's strange from the eye. I would get both. And who are you calling? And what scan are they going to want? Good. Let's see. Oh, we have time for the ears. Okay. Ears. So we are going to spend a whole lot of time, and I will just tell you right now, no slide is different, but I changed the order. So I know that you might have a connection to that. I'm so sorry. Just change the order. The content is not different. I'm just trying to make it more clear for clarity purposes. Again, so we're talking about, we have moved from the eye, now to the ear. Definitions, back from hint. Otalgia, when it hurts. Otorrhea, when it's draining out of the ear, so some sort of drainage. Just for definitions. Remember where we're talking about, the anatomy. So when we are talking about otitis media, it is in the middle ear. So you're looking at that middle ear, where that is, and how it connects to the eustachian tube. During the break we were talking about, well, what comes first? And in kids, a lot of times, you have no idea. So the order of what symptom is first is going to be super important. Was it really the ear that started hurting? Because that's more likely an ear infection. Was it the eyes? Was it the cough, congestion, runny nose, and now the ear or the eye is secondary? So that can really help you to see what seeded what. And you're looking at what is that underlying etiology. So some of our definitions. And this is usually where I lose people. So let's not lose each other here, okay? The definition of acute otitis media. This means it is in the middle ear, in the media, behind the tympanic membrane. It is acute otitis, so it is an infectious source. So that is the problem. That is an ear infection. The ear The middle ear is the problem. That's where it's infected. That's what the problem is, acute otitis media, okay? That is different than an otitis media with effusion. So in otitis media with effusion, you can have the child be sick, virus, bacteria, whatever's going on, and you see there's fluid behind this ear. Maybe it's a little murky, maybe not, but that's not where that primary infection is. It's a secondary kind of manifestation of what's going on from the primary source. That is an otitis media with effusion. Both of these are going to start often as a middle ear effusion. So there's fluid behind the TM. So you start with that fluid, and then is that the infectious source, acute otitis media, or is it secondary from the otitis media with effusion? Okay. This gets people real mixed up, so we'll go through a lot of different examples. That's why I changed up some of the slides to try something different this time. Okay, so let's start in the middle. There's this middle ear effusion. You look behind, or you look inside that ear, and you see that there is fluid behind there, and you're like, I don't know which one this is. That's where your history, and that's where the different definitions of what is what come into place. You can go either one of these. So, if there is that middle ear effusion, and you have an acute process, so you have ear pain, you have redness of the TM, you have that distinct bulging and the purulent fluid behind the TM, now you're in otitis media land, acute otitis media, AOM. If you just have none of that acute inflammation, you just happen to see that fluid and they're sick, now you have otitis media with effusion. Which one's the source, which one's secondary? Separate those out. So a normal TM, so this is what you're looking at. So normal up top, okay? Looks normal, I can see the light, I can see all the landmarks. Now I'm looking over at the effusion. So I can't tell necessarily from this if this is an otitis media with effusion or if this is a middle ear effusion. I need the rest of the history to tell me what's going on. All I see is fluid behind that TM. Versus, I see fluid, I see purulent drainage, I see a bulging, I see this injected TM. That is my source of infection there. That is acute otitis media. In residency, and we're going to play some of this today, in residency we used to have a game we would play, and it'd be a little bit smaller, but it was either pictures of otitis media or an infected cervix. Okay, so we would have those two that we would play the difference between. So can you tell your anatomy? Can you tell what's going on? Is it truly an otitis media or an infected cervix? So they look very similar. Which, all of that to say, not going to necessarily do that, but if you think to yourself, I'm looking in this ear and you're like, that looks like a mini infected cervix, that's probably otitis, right? It looks really similar, right? If you're thinking like, I don't know, probably not. Right? So if you think infected cervix, otitis media. Acute otitis media. There, thank you. So who's going to be at risk? Why do we spend so much time? Why do I have like 30 slides on otitis media, acute otitis media? Well, because it happens a ton. Under the age of 2, specifically for their anatomy. Remember we talked about these little babies from block 1? Their heads are gigantic. They're an egg on toothpicks, right? So this gigantic head also has a kind of squished little face because the brain is so much bigger. And so the ear canal is much more horizontal than the adult. So if you look at your neighbor next to you, your chin to ear should have a slant down. Right? You should see that that eustachian tube has gravity to help it. If you look at a child, those are often in parallel, more horizontal. That creates a stagnant pond. That stagnant pond does what stagnant ponds do. It tends to grow pathogens. So under the age of 2, alone puts you at risk of that stagnant pond because of the anatomy. Formula fed could be one of those because you don't have that excess amount of antibodies. Tobacco smoke exposure is going to create a pro-inflammatory state. Tank hair attendance because you're exposed to everything under the sun. Respiratory allergies, again, pro-inflammatory state. Not vaccinated, most are more likely for different things. And then back from block 1 where we talked about There's certain different types, trisomy 21 being an example, where you have those small auditory canals already, so your anatomy was slightly different, and that's going to put you more at risk of that. This is what I was talking about. If you look at that eustachian tube, in a young child, particularly under the age of 2, it's much more horizontal, so stagnant pond. Anatomical reasons, so most of these children are going to have, 80% of kids are going to have an ear infection by the time they're toddlers. So this is the bread and butter of pediatrics. That's why I need you guys to know this, because again, I don't want you to prescribe inappropriately or not figure out which is which. Let's see, what do I want to say? Recurrent, we'll talk about what the definition of recurrent, but if you get to the point where you're like, hey Tommy, it's the next one, and you're seeing this kid over and over and over, that's when you start thinking, maybe this kid needs some pressure equalizing tubes, PE tubes, nostomy tubes. Because what you don't want to do is have this functionally, number one, be a physical purulent barrier for sound conduction, that changes with their speech patterns, or number two, seed anything else that is going to cause some hearing loss in this child. So you certainly don't want that. Your same common bacteria, any of those heat things and viruses can cause that pro-inflammatory state as well. However, how many of you have been around a sick child? Right? How does that go? If you're trying to write poorly, right? How many limbs does a sick child have? Like 8. They're like octopus, like octopi, I guess. Like when you have a sick child who now you're a stranger examining the ear that hurts in this child, they grow tentacles and all kinds of things come out. It is very hard to examine this. So number one, you have a poor subject sometimes to examine. Number two, then you're trying to hold them down. And what do kids normally do when you're holding them down? They scream. And when a child is screaming, what does that do to the vascularization in their head? It increases it. So is that going to make your tympanic membrane more or less red? More red. So now you have a febrile, potentially, screaming child, and then someone says, yeah, there's a red tympanic membrane. And you're like, thank you, Sherlock. That was super helpful, right? If you think physiologically, that makes absolute sense. But is that actually a true otitis media? So that is one of the reasons why you see so much overprescribing, because it's really common, but the diagnosis is really difficult. Cooperation, anatomy, sometimes it's blocked with cerumen. They grow octopus limbs, all kinds of different things. So what do you need then to diagnose? Well, you need a couple of things. Number one, for a true acute otitis media, meaning that's the problem. That is the problem. That's what we're trying to target. You need acute onset of symptoms. So typically, this will be in the form of their ear has been hurting for X number of days. So that's where it can really matter. What started first? The ear or something else? So acute signs of this. Then you have that effusion. So you see there's fluid behind the ear. So you gotta have fluid there, or else you don't even have anything going on. But then, does it start looking like that cervix, like the infected cervix? So is it bulging? Do you have purulent fluid behind it? Are you seeing that the TM itself looks like a different color, where it's either kind of that yellowish color, or that it is injected, and it is super, super angry? If you're looking at TM mobility, you see that loss of mobility, because now there's all that purulent fluid behind it in a fixed space. You see that loss of mobility. You can see ear fluid levels, so if you're looking and you're like, I think there's like bubbles, or I think like I can see some fluid, it's probably, trust your exam, it's probably exactly what you're seeing. And then if it ruptures, that's actually helpful because now you knew the diagnosis. You're like, well, that was otitis media because it had so much pressure buildup that it punctured the TM, and now you have otorrhea as a secondary. So you have some sort of effusion, it has happened acutely, and you have signs of that inflammation. So is the TM erythematous, is there pain, is there some sort of the itis part of it? So you're looking, A, does that look normal to you? It looks pretty normal, pretty flat. See the cone of light, see all the stuff. What do I see with B? Yeah, I see some fluid, I see a little bulging. I don't really know what's going on. I need a little bit more history there. What about C? I see a lot of bulging, plus or minus that history. And then does D look like a cervix? Yeah, D looks like a cervix. So slightly different, but this is still you're going to need that patient history. Even though it looks like a cervix, you need the history to go with it to see what's going on with them. Oh, but what about this one? Does this look like an infected cervix? Yes. So now I see the injected. So it's injected. So you know you have the erythema. I see that purulent fluid behind it. It's bulging, and the history is probably going to be this. They've been pulling on their ear and fevers for 2 days, something like that. So this is an example. Again, if you see it looks like an infected cervix, pituitary media. So it's going to matter then how old they are, what we're going to do with them. So it's going to be important to know. But please treat the pain. So this is why this kiddo came in here. This is why they're screaming. This is why they're not eating. This is why they're not drinking. It hurts them. So our antibiotics is going to help with the pain. Not right away. So treat this kiddo's pain to help them be able to drink using your Tylenol, acetaminophen, and ibuprofen in those higher dose range. Again, what is Tylenol's dose or acetaminophen's dose? 10 to 15. Go with the 15. And then ibuprofen, 10. Yep. You can do watch and wait. A lot of parents will come at you with ice picks for your own eyes if you try to make them watch and wait. So we'll talk about when is that appropriate and when it's not. Okay, so this is going to be who do you treat and when do you treat them. So we'll first look in that below 6 months range, they typically still have maternal antibodies. So if you're like, well, it's my 2-month-old, like what am I going to do with them? And this is really why at the 2-week, 2-month, and 4-month visits, I'm functionally not even looking in the ears. I don't gain anything. They have maternal antibodies, and if they're not having any symptoms, I've just pissed off a baby. And while I'm in the business of that, sometimes you don't need to invite it. Okay? So starting at about 6 months, and then up to 2 years is your first set of guidelines. So if you see that first top, otorrhea, so this baby is presenting with stuff coming out of their ear, and they had acute otitis media, so you know it's that because it's coming out, it's ruptured, you are absolutely going to treat with antibiotics. No questions asked. If it is unilateral, one side or both sides, and they have severe symptoms, and so you say, Dr. Klein, what does severe symptoms mean? It feels vague. So either they have had severe pain that is causing them to act much different than their normal for more than 48 hours. They have a fever that is over 39 degrees Celsius, so up in that like high 102 range for more than 2 days. If they look sick, you look at this kid and they look really sick, it's going to be a severe symptom. If they've got that and they're in that 6 month to 2 year, certainly treat that. Treat that with antibiotics. If they're under 2 and it's both ears under 2, you treat them. So you're worried more about the risk-benefit ratio of long-term complications. The only thing would be if then they have one ear infected under the age of 2, one ear with no severe symptoms and no otorrhea, you could do watch and wait or treat. It's the only ones that you can do that with. Now once they're over the age of 2, so if you still had that confirmed diagnosis with otorrhea, still treat. If you still have severe symptoms at any time, you treat. But now you can watch and wait if it's bilateral or unilateral. So if you have a family that's like, can we just wait a couple more days? I really don't want to give them antibiotics. That's absolutely within the guidelines. So those are your distinction. Over 2, under 2, unilateral, bilateral. So know those know that specific detail. If you want to study this way, it's the same stuff. It's going to give you this. It's going to give us what's on the next slide. This one, I need you to star, highlight, underline. You will need to know these doses, okay? Your first line treatment then for acute otitis media. So you're like, I'm going to treat this. First line, is amoxicillin. And is this group A strep? Do I know that this is group A strep? No. So is this going to be low dose or high dose? High dose, yes. So high dose amoxicillin, which is 80 to 90 mg per kg per day. And I, again, go up to 90, assuming they're going to spit it up, throw it up. Mom or dad's going to spill it. It's going to be a disaster somehow. It's totally fine. Dose high. So that is going to be your dose of amoxicillin. Twice a day, and we usually go 10 days. This is the bubblegum medicine. So if you've never been around kids or you don't have it, amoxicillin is the pink bubblegum medicine. So a lot of times families will just come in and that's all they'll say. That's what amoxicillin is. If or when that doesn't work and you're having to step it up, your next dose or your next medication will be amoxiclav. So still at the high dose range, 90 mg per kg. You're dosing that based on the amoxicillin component. Still twice a day, still 10 days. The next one, oh, quick with that. Your patients, has anyone ever had Augmentin? So this is amoxiclav. Yes, anybody ever had that? This will give your patients, your adult patients, and your pediatric patients, profound diarrhea. They will have a lot of diarrhea, and then they will come back to you with a secondary, especially female or a child, yeast infection. So if you are going to give amoxiclav, make sure you have thought about that, or be prepared to see them again. It's pretty standard. The next one you're going to give, so you're now third line, is ceftonir, oral ceftonir. Very strange dosing. It is not a typo. It is correct, and it is very strange. It is 14 mg per kg per day. That's a weird one. You can do this in one big dose. It's a lot, though. You split it up into the 2 doses, again, 5 to 10 days. This one is one that you're probably going to forget this, but someday I remember that, oh yeah, I've heard this somewhere. This antibiotic makes a child's poop Sedona red clay colored. So they will come back in thinking that they're having bloody stools. It is a side effect of ceftonir. So not blood, that is a well-known side effect of liquid ceftonir. So if you do that, because now you're like, we're on our 3rd antibiotic and we're having bloody stools. Nope, it's the ceftonir. Your 4th one is then ceftriaxone. So if you are up there, now you are 50 milligrams per kilogram. And notice we have switched over to either giving this IM or IV. So we have had a big jump up there, and that it is 3 days. So you will see this child 3 days in a row, an IM injection of ceftriaxone. I want you to at least know, let's just do one of the alternate agents. So if you have a child who is a true penicillin allergy, beta-lactam allergy, the dose of azithromycin would be your next go-to, 10 milligrams per kg, and then 5 on the subsequent days. So we treat that with a course of azithromycin. So what I need you guys to know here is amoxiclav, ceftonir, ceftriaxone, azithromycin. All the things related to those ones. Because that is what you as a primary care PA will be responsible for. What are those complications then? So one of them is going to be that now they have this persistent effusion. So you got rid of the infectious part with the antibiotics, but that fluid still remains. So this persistent middle ear effusion. So it started that way, and now it's ending that way again. So this is what you're going to be monitoring for, because this can last for several months. And over the course of those several months, what you're worried about is that speech and language going to be involved at all. So making sure that you're doing a follow-up. Is that effusion gone? Is their hearing affected? So if you see a persistent effusion more than 3 months, that's when you need to send them to audiology to make sure their hearing and their speech is not affected. The other thing that you will send after you know their hearing is okay is the evaluation for ENT. Do we need to do something to get that fluid out and to make sure that it's not going to lead to a problem? Audiology first, ENT second. So it's a little different than block 1, where you had a speech and language concern. That was audiology first, then speech. If it's persistent effusion, audiology first, now ENT second. What about this? So this is the biggest one. Is this the etiology, acute otitis media, or is it otitis media with effusion? So you see this all the time, the otitis media with effusion, because they're sick with other things, sick with a virus, cough, cold, adenovirus, fever and a rash, all of these different things. But is the ear infection really what the infectious etiology is? So that is what you were trained to distinguish with your diagnostic skills. Super common under 2 because they're getting all these different viruses. And then you see the most frequent thing that you're going to see. So that's an example too of those air fluid levels. You see that in kids, really it looks like bubbles. Some of the times you're fighting these is totally incidental. On exam, the kid is getting over a cold or they're starting a cold, and so a lot of times you are seeing that middle ear effusion or the otitis media with effusion on exam, totally incidental. Supportive management, you're not treating this with antibiotics. So you might end up to the point where that stagnant pond does start growing something and they come back. So you hear that a lot. I went and I saw this provider 2 or 3 times and it was 10 days later that's when they treated him for an ear infection. You're like, yes, the physiology, that checks. It's absolutely what happened. Recurrent then. So what do you do about this recurrent? So this is one that I need you to know as well. So let's say that you see a patient on March 1st and you diagnose them with an acute otitis media. This is the infectious source. I am going to start with amoxicillin 90 mg per kg per day divided BID for 10 days. They come back to you on March 15th. So less than 1 month from that initial time of diagnosis with the same symptoms. You're like, that ear looks the exact same. Step up your treatment. So what's your next one after amoxicillin? Augmentin, Moxclap, yep. So now it's within that 1 month. You assume I have resistance and I'm still having issues. It's within that 1 month. They were compliant with treatment. We are stepping up to the next antibiotic. Okay? You diagnose them with acute otitis media on March 1st. And on April 4th, they come back. What do you do this time? You go back to amoxicillin. You assume since it's been more than 1 month that it is a new infection, that they cleared the first infection appropriately, and it is a new infection. So that 1 month mark is really where you're delineating that. And you can do this as many times until you either get to, this happened 3 times within 6 months, or 4 times within a year, or they've had that otitis media with effusion that's persisted more than 3 months. Those ones are the ones that need to go to ENT. So those are the ones with the parents that are holding onto your collar, desperate, send us to ENT for tubes. Those are those ones that are desperate. So 3 times in 6 months, 4 times within a year, or persistent otitis media with effusion. Those are those 3 things that you're going to send automatically for a surgical eval. The less common complications, because the anatomy is so close, you can seed anywhere else. So you are most worried that it's going to seed over into the mastoid. You're going to end up with mastoiditis. So that post-auricular tenderness right over the mastoid. You're going to see the pinna is pulled downward and out, which actually brings me to one of the things I forgot to mention with that. When you are looking in a child's ear, that physical exam is going to look different than your adults. What are you doing for an adult ear exam to see the canal? Pulling up. With a child, you pull down and back. So the canal is shaped a little bit different. So just be mindful of that. If you just pull up, you're just going to hit the side wall. You won't be able to see anything. So down and back is for our kiddo. Mastoiditis cholesteatoma is another one. So if you have an epithelial growth that occurs in that middle ear, you can see that sometimes with this chronic inflammatory process. And then because it is connected, it can seed anywhere else. So you can see any kind of abscess anywhere there. You can see a thrombosis up in there. All of those are certainly big bad complications in order to go to ENT. I don't know why I put that in there. Okay, so what do you see here? Do you see fluid? Yeah, so what if you're just in clinic, this kid is totally well. What is this then? I would just say a middle ear effusion, right? Kid's totally well, but I see fluid behind the middle ear effusion. Okay? What if I tell you this child? This child, let's see, is 18 months old and started having a cough 2 days ago. No ear complaints though. Otitis media with effusion. Yep. So you have secondary symptoms going on with a viral URI. I say this child is the 18-month-old twin who's had 2 days of ear pain and fevers up to 102. Yep. This one is an otitis media, acute otitis media. Looks like a cervix. Okay? Looks like an infected cervix. Actually, before we jump into that, that's a good place to stop. So otitis media, I need you to know the ins and the outs, what it looks like, pictures, diagnostic criteria, how to distinguish it, antibiotics, no otitis media forwards and backwards, okay? And I will see you Wednesday.